they're progressing, probably starts to have speech, and it comes in fairly easily. It could come later, 2, 3. You have to check out hearing, all the other things, you know, but they have speech, they're babbling, they're starting to say certain words, they have a variety of sounds. They might not sound right or they might not be produced right, but they have the ease to get it out, okay? And it just might sound like a bunch of mush, and these children also have maybe better, they can make a sound or a word or a syllable much clearer than they could make a sentence, okay? Then you have apraxia. That's an inability to motor plan. That's when your brain knows what it wants to say, but it just can't get it out of your mouth. And in true apraxia, for me, a 5-year-old doesn't have any speech. And those are the kids, we did a summer program 2 years ago. We had really half verbal and half nonverbal, and it was really a good learning experience for me because you had all those kids with dysarthria that are, and they're talking, and they have some words and phrases, and you know, and there's practice things they say, like, you know, that their mothers and their, you know, say, hi honey, you know, and those come out. But and so they have those practice phrases, they're better at one word, and that's a 5-year-old. A 5-year-old that has apraxia looks like this. And I just literally can't get it out, or shrieks, right? Or is so frustrated, or totally shuts down. And I'm not saying you cannot be diagnosed before. It's good to be diagnosed before if you have a provider who can help you kind of dissociate dysarthria and apraxia. Because a lot of times if you have really low tone and really low strength, you cannot be speaking to, and they play this, they're interwoven. But apraxia at 5, if your child's not speaking, that's pretty straight out diagnosis. Motor planning disorder is difficulty formulating motor plan. This is a child who's growing up and has maybe a few words, has a few sounds, and they also have dysarthria, we know that, so they've got the cocktail together. But these are the kids that will slowly get better, and especially with great intervention, they will start to take off. And these are also kids who might be very frustrated and have a very low tolerance for work. I mean, I had one little boy who just comes in and just puts his head down. And this is sad. He has such a low tolerance, right? Because everyone's like, do this, and he can't. And so, you know, he knows what he can and cannot do. Yes, questions on this?
Do you want to sit over there?
No.
Sit over there.
Because probably has it. And I would say my mom understands him about but my speech therapist that was coming to our house before he started was saying that I guess he drops all of his at the end of his
spinal
consonants. Yeah. And I think he first might drop the I don't know. But
do you want another reason why?
well, I was going to tell you what she said.
What'd she say?
Because I was like, she said, because he's so damn excited about what he wants to talk about, and they can't get it out fast enough. Because he's like so happy. Tell me everything.
You want to sit there?
So she just said, he has so much going through his brain.
Can I bring the
he's
chair
so,
over there?
Smart, but he just can't match up to the speed.
Well, I think typical kids have some funky speech patterns too. And a lot of times when you pull literacy into it, those funky speech patterns kind of solidify more because they're matching sounds with letters and learning words and kind of those things. So for a typical child to look like that, I would think that reinforcement would help. For our kids, if they're dropping the sounds, a lot of times what we think is the jaw. They just can't support the length of the word. You also have to think about hearing. Is he hearing final consonants on the end of the words? You know, does he have tubes? Does he have low frequency hearing loss or high frequency hearing loss? Things like that come into play. but a lot of times when kids are dropping sounds or dropping syllables in words, it's just because their mouth can't support it. It's like, here's something really weak, go run a marathon. You know, it's like, say this sentence, or say this long word, but I can't, Mom, because I just don't have the endurance to do that.
And also, the abdominal.
Yeah, airflow. Airflow is another big one. You're right. A lot of kids only breathe, and they take in shallow breaths.
As well as chronic sinusitis for about 3 weeks out of every month. So I was like hoping and praying to God that when we do that, his hearing will be 1,000 times better, and that his speech might come in. Because I would say if there was a way to really potential or how many words, I mean, I would say he's looking
I think so too.
yeah, so.
I mean, you know, when you have all of that sinusitis stuff and everything going on, hearing fluctuates so much, and it's just like, you don't even know it, right? Because when our kids can't feel, they can't tell. Okay, when our kids can't feel, they can't feel those impulses to go to the bathroom. They have high pain tolerance, right? So you never know they have stuff in their ears. You have to go to the ENT for that, right? I mean, even the pediatrician misses fluid in the ears, and then they're sitting like underwater their whole lives, basically.
I had a cold. Because we all share colds.
I know.
And so I've had a cold for like 6 weeks, and I was just living underwater, and I was like, my first time, yeah, living underwater.
Yeah, take a bath, go underwater, and try to talk to your kids. That is what your child hears all the time. If they have chronic stuff, which a lot of them do, and a little bit of a soapbox, dairy gluten, I found it, a lot of my kids go off of it, and all that sinus stuff goes away. So it's just something I've seen a lot. Yeah.
So when they drop sounds, like my daughter can say sail and she can say boat, but when she says sailboat, she drops the S and it's elbow. The S and the T.
Think about it.
What do you-
Think about it. Like if it's exactly what we just said. It's having enough strength and endurance to say a short thing, short word, but not enough to say both. Right?
So it's an endurance.
It's an endurance and strength thing. And the thing is like with little kids, if they have, like to your question in the front here, if they're developing words and syllables and they're pretty good at 2 and 3, and you're like, this is awesome, we don't need any of this stuff, we're over it. What happens is their language starts to surpass their jaw ability, and then you're like, oh my gosh, all of her speech is going to mush now when I get these longer utterances, right? And so then you're like, what just happened right now? Like, I thought we were good and free and clear. But wait a minute, that's what just happened. And a lot of even my kids that I work with, and they have these huge language outbursts, and you know, and you're like, yeah, they're saying sentences, and then all their articulation just, because their jaw is just not there yet. It's a huge testament. And even in typical kids, if they can say clear words at the single word level, and they can't at the sentence level, it is a jaw thing. I mean, this doesn't just span Down syndrome, let me tell you. We have typical kids, adults, people sitting in here. If you have a little bit of a lisp, if you speak and your jaw moves side to side, you can see it in anybody.
Numbers, for example, 15, 14, and then you go to this 40, 50. But adding N, the N for the short, not like T numbers, then T, but in 40, 14.
Oh, it's just a motor pattern that he's learned. So he said 14 and 15 for so long. It's just a motor planning thing. So we teach our kids these motor plans, and motor plan is just a word. And then what happens is when we go into a new word, they just use the old motor plan and put it in the new one. You just have to learn a new motor plan. You just practice those words. Yeah. Well, you know, there is an underlying strength issue, so you have to look at the whole mouth and the whole body before, you go into all your specific. Okay. Feeding profiles. Okay, these are profiles that I have created based on the kids that I see. I'm gonna read them to you, and if you see it, how you read it. Child A eats everything that the family eats, stuffs his mouth, and is quite messy during mealtime. He can or has choked on food. He drinks from a straw, but his tongue wraps under the straw and can often be seen protruding from his lips. His parents often don't think he has a feeding difficulty because he eats everything. Why? This is a child that either has some chewing ability or not. He often chews 3 times, then swallows his food whole because his tongue and jaw are not working properly to hold food on his molars while chewing. He often cannot feel what's going on in his mouth, which is hyposensitivity. He has unresolved tongue protrusion and a low open jaw position, which affects his speech development. This child has dysarthria of speech. Can anyone relate to that? Child B eats only crunchy, dissolvable things like crackers, chips, and prefers purees and softer foods like bananas, cheese, ground meats, like chicken nuggets, obviously. And brown rice. This child lacks fresh fruits, vegetables, and often meats. This child chokes on food occasionally. Why? He eats crunchy, dissolvable foods because these foods provide him with sensory awareness when they crunch. He can feel these specific foods, but has such reduced sensation, that's hyposensitivity again, and overall oral skills that dissolvable foods are safest. Soft solids are also safe because he can mash them with his tongue on the roof of his mouth, and it looks like this. And supple swallow them without chewing. You may think he chooses because his mouth looks like it's going up and down, right? But he's not. It's really tongue movement. And that's really an infant's suckling pattern put into a 3-year-old, put into an 8-year-old. It's the same thing. These children have tongue protrusion, open mouth posture, and decreased speech clarity. This child also has dysarthria. Anybody resonate with that? Child 3 drinks only one type of juice, eats the same limited brand-specific bunch of foods each day. You have to pack food for this child every time you go out. His diet is often nutrient depleted. Why? His food choices are controlled by subconscious and or very obvious fear. He has extremely limited skill in his jaw, tongue, and lips. He watches you make his food, place his food, and feed him his food. His oral sensory profile may be characterized by tactile defensiveness and mixed sensation. Tactile defensiveness is that learned tendency to respond negatively or emotionally to tactile input. Mixed sensation is when a child has a combination of either hyper, hypo, or normalized sensitivity, all within their mouth. This can be very confusing for a child to process and manage food. These children often have apraxia of speech coupled with dysarthria. Anybody resonate? Speaking my mother. All right. Child D is over the age of 3 and only drinks milk or Pediasure from a baby bottle or adapted sports bottle. He perhaps eats purees and baby food, but perhaps not. This child is nutrient depleted. Why? This child lacks the ability to move his jaw up and down in a chewing manner because he has never done it before. This child has very low tone, by the way. He may swing his jaw side to side regularly. He has very low muscle tone and strength in his entire body and has practiced an infantile suckling pattern for years on this baby bottle. His tongue thrust is large and he would not know how to manage food if he tried, which he never would. This child is hyposensitive, or it could be mixed sensitivity. This child is void of a variety of nutrients that children need. This child can be mistakenly diagnosed with apraxia, but needs intensive oral motor work to strengthen and create motor patterns for speech development. Does anybody resonate with that one? That's a tough one. That child probably walks at 4. Does anybody have any questions about some of those?
Yeah, I'm trying to think. I think my son is more like a child C that has the mix. He's got fairly good speech. He's 8. Definitely I see the weakness, because when he starts talking in sentences, then it starts decreasing the volume, the tone, and all that stuff. But he only likes meat. And he'll go with the chicken nuggets, but he'll go with the steaks. And he likes spicy foods, but there's tons of waters with it. But he will not touch breads, the softer ones, but he'll touch
He
chips.
just has a lot of fear behind the food. So he's latched on to the foods that you make him, that he gives him, that you give him, that he knows are safe, and he's masticating them however he does, whether it, probably not chewing completely, and he's swallowing them. And he's just created his safe space. And so for you to introduce those other foods, you would need to introduce some type of program to help him gain strength, control, sensation, so that he feels trust with you.
Oh, okay. Yeah, because I mean, it just varies. Like right now, his favorite is pot stickers. And that's a combination of soft with some, it's mostly soft, but then it's slightly different as opposed to just pure
Yes.
meat.
Right, yeah, there are two things, but they're both soft, and they both could be suckled and swallowed down pretty easily. Yeah. Yes.
So you were talking about the trust and the fear, and when we talked earlier, you said the same thing, this kind of fear. That's one of the things, family members and friends have said is, you baby him too much.
It's not you. It is not you.
Well, that's what I was gonna ask, is
You
you
gotta
talking
take it
about
out.
the fear of the
Yeah.
food and stuff, and I just feel like we pushed him so hard at one point because we tried the easy route, and then we tried the hard route,
Right.
and now I feel like, okay, I know it's his diagnosis, but also, it's like, what did I do wrong
No,
to
no,
make
no.
him crave
It is
the
not
food?
It is
Because
so not you.
it feels like it sometimes. It's like you try to feed him, and then I have gotten him into this niche where, that's what I make him every day, and it's gotten to where, it's both of us.
It's nutrition.
He's getting everything he needs, but it's also, sometimes I'm like, well, maybe I'm not trying hard enough, because we both kind of got in the rut of, it's easier for me to just puree his food and feed it to him. He won't eat with his own spoon most of the time. He still takes a bottle 3 times a day.
How old is he?
He's 3.
You know what? You don't know what you don't know. And it's like mind-blowing for me sometimes, because you tried everything, and now you're learning about something new, right? And so you just didn't know, and so you've done everything you can, and now you have to get nutrition into him,
Yeah.
right?
And liquid.
It's so
This is what-
important to feed him. So maybe we can try some new things with him and get you out of your rut.
Yeah, it's just, we've seen other OTs, and I feel frustrated because they told me, you have to wait till I understand, both of them, you have to wait till I understand the words. So of course, when I hear that twice, I'm like,
Of course,
okay, he just cognitively doesn't get this, but he can, he will, but now I'm frustrated because I feel like I could have done more for him, and he wouldn't be doing,
Yeah.
so I'm afraid that by waiting, that I put that fear of the.
You know what, it is, you can just kind of clear the slate and just kind of start now. You didn't do it.
How long does it take to get over the people's?
That is so child specific.
Okay.
I know, I'm so sorry. Anybody else? Yes.
Our son, every time he eats, he wants to drink. Like every spoon, he wants to drink, like to wash his mouth out.
So perhaps it's the way in which he's propelling food down. Perhaps his mouth doesn't know how to move his food and pull it back.
And I went to the Lucio Packer OT feeding specialist, and she says, well, if you think about this is a safe way for him to swallow the food. So she says, I wouldn't worry about it. I said, well, he's drinking all this water, and while he's eating, and
Not getting enough calories.
and she's like, well, but as long as he just found this way of eating, it's easier for him. But I feel like it's not giving him enough time to chew, because the water's gonna wash it down. But if I don't give it to him, if he asks for water, he wants his water. So it's like.
Well, it is a safe way to get something down, right? Some kids put their whole hand in their mouth to get their food back. Yeah, and I mean, it just means that his tongue and his cheeks and his jaw are not working in collaboration the right way. He's outsmarting you. And behavior is communication, right? We hear that so much. I know, right? I have so much more. Okay.
I have listed out the choking.
Yeah.
Why does it happen? Like, does it happen in a couple of components? So, yeah, I've told
Well,
my
if
one.
you cannot feel what's going on in your mouth, then you have a higher risk of choking because your food gets pocketed here, or it sticks up on your palate, comes down, and it's like, ooh, there it is. Or you can't feel, and so you can't chew your food all the way. So you have a big piece go down, and there it is. And so there's so many reasons, and they revolve around: does your child know how to chew? Is he chewing fully? Can he feel? Yeah. Yeah, because he cannot feel it. Yeah. Yeah. Yeah, you use so many different tools. We were about to go through them really fast. Here. All right, first I have to introduce you to Cora, because hello, how cute is that? Cora's pretty amazing. She started oral placement therapy really early, and she's becoming this amazing talker. She's like 3. Same with Will. Sentences, just incredible. And they're like 3 and 5. Emma started when she was 18, totally unintelligible. And now she's out, again, on dates, working at the Academy of Sciences in San Francisco. She's a greeter if you're ever there and see her. She's incredible. She's this woman who, hi Heather, how's your mother? Like, how are the girls? Oh, my dogs. How's your husband, Mark? What are you guys doing? When are you moving? I mean, so intelligent, but no one could understand her for 18 years, But now she's so intelligible. She's amazing. Okay. All right, this is a big one here. All right. How many people have some tools at home? Okay. All right, so here's my thoughts. My thought is that I wanted to show you some things tonight so that you can kind of see what the tools are. Going home and trying a whole bunch of stuff is going to be really frustrating. So perhaps if you just try the one thing you have, that's a great idea. But I want to give you some guidelines because I know you're going to be excited, and tomorrow you're going to be like shoving things in your kid's mouth. And then 2 days later, you're like, it doesn't work, And so, so without me actually hands-on with your child in you, I'm going to give you some guidelines, okay? But you should probably still get some, assessment or some help. So the most important guidelines to understand when starting an oral placement therapy program, when you're using, your jaw should always be in the middle. It should always be aligned. Okay, this is your natural position, right? Smile, open, this, up and down. If your jaw is ever sliding side to side, stop. You don't speak that way. You chew in a rotary pattern, okay, I'll give it to you. But you don't speak that way, and you don't use tools that way. So if you are putting a chewy tube in your child's mouth and they're going like this, or here, or side, and sliding, it's not working. It's not the right technique at this time, or you need a different technique. Okay, you probably need 2 chewy tubes to help line up. So everything you're doing with your child needs to be in alignment. Also, all the tools should be held either at midline, like a straw, a horn, all at midline, and not to the side. And yeah, okay, that's all. And tools, yes, should always be used in your child's natural position. That goes with speaking. Should always happen in this up and down position. It should never happen to the side. If you are practicing at home, consonant interval, boo, and your child goes boo, like that, stop practicing it that way because you're only reinforcing boo. You need to put your hands on your child, boo, and get them at midline. Because practice makes permanent. You learned that in softball. So you need to always, it is always a good idea to give jaw support. If you're speaking, if you're practicing any speech with your, that your speech therapist has sent home, hold the jaw. Have your child talk at midline only. You're practicing, you're practicing. You also need to implement some strengthening into that too. You can't just hold the jaw forever and expect great things, but it is the way in which to practice in the right functional patterns, right? Because you just, motor planning is so important, whether you have apraxia or you don't. If you practice one way, it's going to stick that way. Let's see. Oh, I like this. I always tell this to speech therapists who are starting out with this. Your child should always produce a sound the same way you do, and your child should always eat the same way you do. So if you go home and you're like, well, she just said a lot of stuff, I don't even know where to start, just watch your kid eat and just be like, huh, he never closes his lips on the spoon. Or, huh, he's doing this. Do I do that? Let me get the mirror. Nope, don't do that, you know? So you just look and just start seeing and taking inventory on what your child does. If your child's saying "ba" like this, "ba, ba, ba, ba," no, that is not how you say it, and so you don't want to reinforce that. That to me tells me that you need to get some tongue retraction in so you can start saying "ba" with lips. So whenever you're practicing anything at home, keep it in the middle, keep it at midline, jaw support, and just do the same way you would do. And with feeding and oral function changes over time. So there are a lot of strategies that we're going to use, and I'm going to teach you and how to get to the right feeding place that you're going to be in. Your child's not just going to start having lateral tongue movement right off the break if you tell your child to do something. And that's a really good point. A lot of times these days what happens is when your child goes to a general kind of speech practitioner who's practicing movements with your child, when your child has tongue protrusion or open jaw posture or any of these things, and they don't have the function necessary like you and me, what it's really like if you compare it and your speech therapist goes, say bubble, and they go, bubble, and you're like, no, put your tongue in, say bubble, and I go, bubble. And it's really like having a PT say, okay, watch me, kid. You know? It's the same thing. Like a PT would never tell your child, like, okay, just watch this, watch me get off the floor and walk. Just like a speech therapist should never just be like, watch me do what I do. Bubble gum. You know, bubble gum. And the child's like, bubble. You know, it's not, our kids don't respond to watch me do what I do when they have impaired oral functioning. You have to change the oral functioning, and then they can participate in general speech just like that. That is the whole goal, is to get them to kind of a normal mouth function, and then they can, you know, learn speech sounds any way you want. Does that make sense? Okay. All right. I think what I'm going to do is just show you some jaw stuff tonight because it's too much. But so possible components of an articulation program. Sensory stimulation, right? Wake up your mouth, wake up, I always do, wake up your body, wake up your face, wake up your mouth. Feeding strategies are included, oral placement therapy techniques, and standard speech therapy approaches. So let's wake up our mouths. We have lots of things that help wake up your mouth if you don't have any babies. So no vibration under age of 1. But you have different things, different vibration tools, like this is a Z-Vibe. You turn it on, it vibrates. It has lots of attachments, like pointy things and spoons. So your baby's not closing the lips on the spoon. Maybe use some vibration. There are a lot. You've probably seen those gator jigglers, those jigglers that they have. You know, things like that. You know, so many tools are used in a program like this from different places. It's just about how you use them. So you're always using a tool to get to your goal. And that's kind of the difference between a program like this and maybe a general program, is that we will build a program for you dependent on the speech sounds that you're working on. So for a baby, M, B, and P, we would do all lip closure activities and some jaw activities. If you're working on ooh and oh, we do lip rounding activities, and we would support the mouth to get there. Okay, I'm going to show you some jaw stuff, and then I'll probably fly through this. So when you go home today, if you have no tools, you can work on the jaw through feeding. So a slow feed is a technique that we use where you take any stick-shaped food. Veggie sticks, you know what those are? Those like French fry chip things that are pretty popular because they have a lot of taste, they dissolve, they're safe. They're a great chewing technique. So you take a veggie stick, you hold your child, put it on their molars, and you ask them to chew. And you only let them chew off a tiny bit, as much as will dissolve in the teeth, so that there's no bits flying around in the mouth for them to spit out or choke on. And then you do it again. And it's kind of like a shredder, if you think of like Bugs Bunny or something, you know, like this. So you're teaching repetitive chewing, which is so important because so many of our kids don't chew. Repetitive chewing, you're teaching tongue tip movement, you're teaching that up and down movement pattern for speech. So many of our babies, when they start learning to chew, M, B, and P come immediately. Ba, 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 ma, 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 pa, pa, pa. Because they have the movement pattern now that they didn't have before. It's so cool to watch. Like within a month or two, it's like bam, yeah.
Any other suggestions besides the veggie stew? For example, my son, he has an aversion to crunchy stuff, crackers, or anything that sounds. He has a lot of sensory issues.
Will he eat anything solid?
He has gotten better. He eats rice, now he eats, vegetables, and but it was all puree. So he has gotten better. But he doesn't eat crackers, bread, nothing crunchy.
Okay. It doesn't have to be crunchy. It can just be in a stick-shaped form. One bit before these is you can use, you can make an ice straw. There we go. You can make an ice straw. And it's like, if you can imagine taking a straw you get from like Starbucks or McDonald's, kind of a little wider straw, putting some of his favorite puree in it, freezing it, and then putting it on the molar and having him chew it. And it's puree, and it's cold. Okay. Gum chewing. I know this seems crazy, but you can teach gum chewing in a nice hierarchy, like around 2 and up. Gum chewing is so awesome for those kids who rock their jaw back and forth all the time, especially a teenager. It can be so appropriate instead of a chewy tube, right? Gum chewing. Absolutely.
How do you get them to swallow it?
Yeah.
That's true.
We teach this. We teach it. Teach it. Yeah. Teach it. Absolutely. You can swallow your gum if you want, but we don't teach it. It always goes in the garbage. So, absolutely, this is great for kids who have so many sensory needs. Okay, let me show you these two. Okay, here's chewy tubes. We use them in an order. We use them in this order: red, yellow, purple, green. You guys need to take a 7-inning stretch. Do you want to do that? I know. I mean, I had so many good questions. Let me show you this jaw stuff, and then we can wrap up. Yeah, I mean, do you want to stand up real quick? Okay. Okay, so we teach red, yellow, purple, and then green, okay? And this is the order in which you start here, then here, then here, then here. If your child has been given something that looks like this, and they've never done a jaw program before, no. We start here, we do it the right way. We do it with good jaw alignment. So if you're doing this by yourself, I would always say use 2, put them in the back, take a bite, take them out. Go back, take a bite. There are always exceptions. But this is where we start. Even with babies, they can be on this or this, depending on the baby. Sometimes, if your child chews their fingers, you pick the tube that is as close to the size of the finger, and you start there. You know, you work it out. You do this. You can do this as many times as your child's jaw will support. 1, 2, 3, go to the side, done. You did 3 good ones, awesome. We stay there. We stay at the level of success, and we don't go into failure. And then you take your next one, and you do the same thing. And if you can, and you move up the hierarchy. This is totally a dumbed-down version of this hierarchy, and I would absolutely teach you per your child, but if you're gonna go home tomorrow and try it, just try these, and make sure the jaw's in alignment. A lot of times what happens is when you go on one side, you get something that looks like this. Yeah. Or here. So kids have very sneaky jaws.
Anything we do all four of those in one.
You can.
Like one
Session. If your child has good stability on all of them, you need to do 2 on these to pass the yellow, 2 on those, 2 and 2. The other thing, the other component for the jaw, welcome, absolutely, drive safely. The other component for the jaw are called bite blocks. They look like this. They come in different grades, and we talked about grades before. They come all the way from this kind of nail file, this really big chunky one, and they target speech sounds. So like these are like E, whereas this would be like a and you use them in your child's mouth and you put them in like this, and there's a whole protocol that you pull.
So what is it?
It's called a jaw grading bite block. If you go to the Top Tools website, you can order these. There are full directions. There are full directions in the Chewy Tubes if you order the Chewy Tube 4-pack as well. We often start on number 2, bite, hold. And a lot of times we start even before that.
With speech therapists, normally working with children in schools, set ever be doing without us knowing what they're doing?
No, probably not, but some speech therapists or paraprofessionals or teachers who have the heart and who want to help absolutely can be trained to use these in school, and that is like your biggest ally right there.
They told me they couldn't do it because they couldn't put anything in the child's mouth because of OSHA.
It is something that we are just trying to educate about right now. Yes.
So can you speak to what are the differences, because I sometimes like confuse myself, as far as what the differences between what you do versus what speech you get like from Kaiser or from school or whatever? What is the difference?
So this program works in a very big hierarchy. So if you look at kind of like all of this stuff I've got in here, I have straws and horns and different tools to help lead your child from where they are to the functioning they need to eat appropriately, to speak with the right placement. I practiced generally for 5 years, and then I felt like, gosh, I want to know kind of a lot about one thing instead of like a little bit about a lot of things, and that's what led me to this. And I know that's how a lot of providers feel. And unfortunately, right now what happens is in a general setting, speech therapists have so many kids, right? And they have to see so many things, and they kind of throw everybody into the groups and everything at school, and it's just not enough. And what's happening right now is this big movement of trying to educate, right? This is a newer therapy. It's not something that's in the schools a lot. Perhaps somebody we've trained is in your school, and talk to me. But I really work on the feel of speech. I work on the foundational development, the strengthening, the stability for your oral function of your child's mouth. And general practitioners usually just work as a watch me do what I do. I work at a level that's foundational under that. And we can absolutely complement each other. Yeah. Yes.
So what you're saying is stay with our speech therapist and go get him assessed by a certified SLP
If-
that does the food.
That does the talk to us.
Right.
That is a great idea. That is a great idea.
So, my son chews on the pea, the purple pea, all the time. That's like his go-to chew toy. Is that bad that he should just chews on it all the time instead of doing, like you were talking about, like this, like, you
Why
know?
don't you watch him chew on it and see if he rocks side to side? If he's chewing up and down on it, then
But it does predominantly go on one side and the other. So then I should take it away from him?
maybe, you know,
Because
maybe
literally his hands are all scabbed up.
maybe you leave it until you get some help. Yeah, yeah. Yeah. There are so many strategies I'm leaving you in your packets for what you can do with your child. Let's see here. I think one thing that you will be very interested in are called apraxia tubes. These are something they're cheap and you can buy quickly and they make a big difference. Like, remember when we were talking about children and when they speak and they go boo and they move to the side like this? This is a tactile shape. It's just red. It's a tube. And we hold the jaw and we put it in the lips and we go ooh. And we teach the right positioning. Ooh. A lot of our kids go flat with ooh too. Ooh. And so we use it and they feel it and then they produce that lip puckering that way. This one's also oh. So you pull the jaw down and you go oh. Oh. And it is a placement tool to help you get the right movement. Oral placement therapy, getting the right placement for your child in feeding and speech.
What's a good age to start?
When your child is starting to make those sounds, so it depends on when you're first getting services, but you can start them, you know, where you are, 18 months, 2, 3, somewhere when your child's starting to make those kinds of sounds. These are shapes, these are great too. This is a visual, it's a tactile, and it's also it's a color. So it's just another way to get information in. You know how we have tactile prompting too? This is just another way. This one is ba, and this one is pa. So we teach children a lot of times with some of these tactile tools so that they start understanding, okay, I need to make a p every time she pulls this thing out. And when I'm saying words like pa for pop, then when she pulls this thing out and I go pa, then I get it. So these are apraxia shapes and tools. If your child has tongue protrusion, then the straw hierarchy is your friend. It is a hierarchy built from an easy straw all the way up to a very hard straw. And when you use them effectively with a jaw program, then you get good lip puckering, good cheek tension, good tongue retraction. The horn hierarchy is another very popular hierarchy, and that's what you use for abdominal grading, right? A lot of times our kids, they cannot have access to airflow. They don't even know how to exhale on command. And so we start with, and we move them onto the horn hierarchy where their abdomen actually gets stronger and stronger and has more endurance and can blow longer. And when you can have more airflow come out, and actually you gain some strength in here, but also you have longer utterances too.
Like bless her heart, but I think she kind of like, I thought she just produced your website. And
Totally.
like made her own tools.
Yeah.
And then, yeah, he didn't want chewy kids in his mouth. He just had clear ones with different sizes. He gave me like a bag of like 50 of them. He used like 2.
Yeah.
Because he doesn't want them.
Yeah.
You know what I mean?
Yeah.
And then we had this like spongy things that
Yeah,
are
too bad.
lollipops.
Yeah.
He wanted that in his mouth.
Yeah.
And it was just like, here's a bag of things to give them.
Right.
So it wasn't like anything I.
It needs to be very directed, right? You have an eval and we try all the things and we see what's successful and then we purchase and then we teach you how to implement. And we work with you every step of the way. It's very small stuff.
For insurance or?
Absolutely. I don't work directly with insurance, but you know how it goes. You submit our bills and then we code it for you.
For Medi-Cal.
Probably would be private.
Yes. Uh-huh. Probably, yeah. People get different reimbursement, absolutely.
But you have to get by like Kaiser.
I don't know about Kaiser. I'm kind of trying to work hard to get in network with Kaiser. I think, you know what, families just submit from all different insurance companies, so I am not I don't know how it all works. I don't think I'm in network, but definitely out of network with many. Just depends on your insurance.
Out of network, all or something.
Hmm?
You are
Oh, it's not. I can't answer that. I don't know. Because the families deal with it.
They say like out of network, for example, some people
It's probably out. It's probably out of network because I'm not affiliated with any specifically. But I will work with you on your coding. If you are getting speech somewhere else, we will code it as feeding and vice versa. Probably some of you are well versed with some of the other tools that are used in speech therapy. But what we do is we do that sensory part, we do the feeding component, and we do those tools that we just showed you, and then we use the general speech therapy techniques and books that everybody gets sent home, and the Coughlin cards and the word flips and all those things. We use it all together. Misconceptions, just to close this out. These are things that are super important. I actually got an email from your network about this one. Children with Down syndrome plateau with their articulation development at 2nd grade. And I think I wrote a big thing back that went over the internet. But children with Down syndrome, they actually will plateau in their skills because their mouth can't support, right, creating any more higher sounds than what they're given, right? But when you actually have a good functioning oral cavity, then you will never plateau. So it just takes the right therapeutic intervention. So if someone's telling you that you have plateaued, perhaps they are right, but the therapy needs to change. Does that make sense? Children with Down syndrome can achieve speech clarity with tongue protrusion. No. You and I don't speak with our tongues out, and that's not going to happen. I've had this happen at IEP meetings. Children with Down syndrome are born with high palatal arches. We've talked about that, and they are not born with high palatal arches. It happens because their tongue hangs low in some cases. Children with DS have to be treated early for speech clarity to be achieved. It's not true. You can start at any age. A mouth is a mouth is a mouth. Emma's mouth, who I treated, she probably had a 2-year-old mouth. Same as Cora. A child with Down syndrome doesn't talk because he has Down syndrome. How many times does someone tell you, like, oh, it's just Down syndrome? Like, sorry. That's not the case, right? It's a diagnosis of dysarthria or apraxia, or motor planning, or both. When you have a chance, go through some of these. These are just parent write-ups about how oral placement therapy has helped their children. Elliot has been receiving it since he was young. He almost has perfect speech. This is an example of a 2-year-old who kind of changed systems, and after like 3 months was drinking from a straw, started babbling and blowing. You know, so these are just nice parent write-ups. This is a child who was 16 whose mother translates for him every day. And, you know, now he is speaking, you know, I love you, Mom, and getting all of those great phrases, and I want pizza, and, you know, and is more independent. And that's just what we all want, is inclusion anyway. This is the website in which supports the company I work for, I don't receive any money from buying anything, just so you know. And I'm happy to take questions. And my website is happykidstherapy.com, and there is so much information on there if you want to go on there. And if you're thinking about an evaluation or starting a program with me, I am happy to give you another parent to talk to kind of hash it all out so that you kind of know what's going on and what to expect. There's so many here, there's so many in the piece, but yeah.
Is there a particular charge that you charge for the evaluation, or is it
Say it
based
again.
on- Is there a charge that you charge, like how much is it for the evaluation, or is it different per child?
Oh, no, every child is $300 for an evaluation.
300, okay, and that's just the evaluation, and then
Yes.
what do you charge for?
It's $150 for 1 hour for service.
And how long is the evaluation?
2 hours. Yeah.
Do kids typically have trouble making it through the whole hour? Like, you know what I mean?
Oh, yeah. It's not even an issue. I've never had an evaluation that's bombed.
Well, I mean, not the evaluation, but I mean like the, like, therapy sessions, like, I mean, I know all of the insurance and hospital or whatever that he's been getting is half an hour, and sometimes we don't make it through the whole half an
Right.
hour before we start, you know.
Because we do feeding and we do speech work and we do so much education. Do you guys want to speak to that? Like, when
We've
Gracie.
never had any problems with it. Gracie's been going since, she's
Yeah.
been going since what?
She was about
3 months, and you know, a 3 month attention span was nothing. But it just seemed like we moved through so many different things, and the whole time she's teaching us how to do it, and really the time goes by like that. And ever since she was little, she would just be so engaged and focused on it.
I mean,
Because
no, but you don't understand what I'm saying.
Yeah.
If you're paying $150 for an hour, you wanna make sure that you're getting the whole hour, right?
Look,
You don't
I am
want
the
it
biggest
melting down or.
advocate for keeping my money in my pocket, but this was something. I don't know. There's many ways of saying that, but after you've done the first one, I will say to you that you know that it's always worthwhile, and you're not. The 45 minutes is only beginning. The month that you're working on it is really what's going to make the difference. All it is them teaching you these skills. You're like, oh, and you start doing them. And you start seeing all this. So you're paying the $150 for a month's worth of services. That's how I always see it, and that's how I always think, oh, totally makes sense. And if you keep on doing it on an interval, you're always having the next step. You're always going the next step forward, and you're always seeing the progress of it. So break it down by 30 days. You know, it ends up being nothing more than $5 a day. You know, and that's how I live. I'm the
Well,
biggest.
but you have to be willing to follow through because you can't
Absolutely.
expect change like progress
1 hour a month
with
is
one
not big.
session or, you know, whatever session that she takes.
I have a question. Would you allow, like, say for example, she wanted to try it, maybe she thought half an hour, could you split a half an hour like with a friend? Say if she went in with a friend, could they do half and half or something similar? No. You know what I mean?
I have to
Split
tell
the
you
hours with
that
the boss.
rushing through something in a half hour is really hard. And I feel like I wouldn't be able to give you what you needed. When you are well trained and you come to my office, I will do half-hour sessions. Or if you have 2 people in one house and you want to do back-to-back half hour and you're really well trained and I see you every week, then maybe, but that hour is used to the fullest, you know?
She comes in and talks to you and like explains like, okay, what's going on, what's new this month, what's her health, any health changes. And all of that contributes to part of your therapy. So you're talking through things for the first 5 minutes and explaining, okay, you know, she was sick for a week, and so, okay, how'd that affect her? What went on? How did she eat? And then she kind of reassesses, and then goes through, you know, this is what we're going to work on. And then, you know, Helen's 18 months. She's only had 2 sessions. And yeah, she was kind of fussy, but she was like, you know, we played with her. We got her to work through it, and we forget it. We're not going to do this. We're going to start feeding her. Then we started feeding her, and then she was like all perky and ready to move on. So she's young, so, you know, we kind of worked with her, but it's not all just 1 full hour of shoving tubes in her mouth and doing all these different things. It's part of it is knowing what's going on with her and how she did with these different therapies for that month and
there's so much education.
It's a lot of education. You're
involved.
taking
There's
it a
so
lot.
much. You are.
Yeah.
And I'll check in with you, right?
Yeah,
I'm
she left
like,
and I was like, whoa.
how'd it go after I left? You know,
Yeah.
because I know it's a lot. And you know what it's like.
And so you said you were in the Bay Area Wednesday, week on Thursday.
Yes,
So
I'm in
how
your
does
area.
that
Yeah,
work? Like, everyone comes to San Jose to see you.
Do we go to you, do you go to that?
You know what? I have an office space at the Down Syndrome Connection in Danville. You are always welcome to see me, Monday through Wednesday there. I have one day a week that I work here on Thursdays, so just depending on how it fills.
Where is that though?
Home visits.
Okay, so it's at the house.
Mhm.
And do you go anywhere?
Well, right
I
now,
know mountains, so.
have you seen the traffic lately?
Morgan Hill?
I am, did you say Morgan Hill? No, I am not in Morgan Hill. I'm really right now in San Jose to Mountain View, Los Altos area is really kind of where I'm standing right now. Redwood City and that is just too far for me and I sit in too much traffic. But if you had a space to come to, if you want to come to me, I'm taking some children on the weekend in Danville, so talk to me. I mean, I'm very specific to working on it.
And someone was talking about groups.
Yes.
Do you ever do like
I'm totally thinking about it right now because I have some, I have some contingency out in the Central Valley that would like to start maybe a group like that, and maybe we work on like jaw work for like a few months together. I'm totally open to it. I was just gonna talk to Amy and to you guys and see what you were available. We can meet at someone's house. You have to have your kid though with you, and it has to be a small group because otherwise it's crazy.
And then how often do you recommend it, the child, or is that done in the evaluation?
You know what, it's really dependent on your finances, your availability, my availability, whatever. I will always leave you so educated, you always can come to me, call me, FaceTime, or whatever. But I see a few kids weekly, most kids every other week, once a month, every 3 weeks. So, I mean, your oral function changes over time, just like PT, so a lot of times I'll see you more in the beginning, and then when you're very trained, then you can not see me as much. It takes a while for people to change. Yes.
I have ABA going right now for the beginning.
That's great.
And for the training.
Yeah.
They come twice a week.
Yeah.
This be too much learning, too much stuff?
No, but also ABA can be very helpful if they want to throw in some of your OPT into their sessions. We can train your ABA provider. If you're open to it.
This is a behavioral group.
Totally. I can train you, we can work on it, but we can also train them if they want to incorporate some of the speech aspect into your therapy, so you're off the hook a little bit.
I also class for the Center of Cancer I've got vendors backlog of so there's supposed to be some I guess and I haven't seen them group that they start doing. It's not for kids, but people doing speech piece and we got to evaluate device speech and that whole thing. So I have hours to do that, and I think it's built for the school district and I've got to how I said that
Let's talk about it. Yeah, I mean, if you're in mediation and,
we're done and it's set, but
yeah.
I don't know what that's.
I don't know, think about, yeah.
Oh, it's just wondering, like, this all sounds really awesome. Do you think I should wait to pursue it until after the pregnancy and May.
May.
Tomorrow's May.
Oh my gosh, okay, let's talk about it. Yes, I do, I mean, yes.
I had the same question as her, and I was probably gonna surgery too. She had rates and, ear tubes.
Yeah.
She'll wait till after that? I mean, especially since he's got blood in his ears, do you think it would make a big difference if we wait until, I mean, I want him to eat.
Yeah, you
right
might
now, so
want
I'm
to.
ready to start like,
I know.
but if it's just gonna be a waste,
Yeah.
then, you know what I mean?
It's not gonna be a waste, but, I don't know, let's talk, will you email me?
I will,
Let's just
I will.
talk about it, yeah,
So
yeah.
it's a good idea to do the evaluation for anybody, but
You
then.
get evaluation and the tools ordered in hand.
I just want to thank Heather for coming out to us.
Yes.
And spending her time with us. we have been blessed to have her in our life for a couple years now, and to have many of you now touch faces with her and hear what she has to say. You can see there's much more out there than just what your schools are going to provide you. And thank you to AIM for hosting us here. They helped us put all this together. Janie and with AIM, if you've never been to AIM before, it's another amazing program that you should really be looking into. If your regional center doesn't tell you about it, it's because they don't want you to know about it, because it does cost them a little bit more, but it is available to you and it is all approved.
If you ask them about it, they'll discourage you from going too, which is what they did when I asked a year or so ago.
Yeah, it's a great program.
What's the age of
Thank you for coming.
It's up to age 4.
Oh.
So, thank you all for coming, and if we just give her one big
You guys fill out those sheets for me and just tell me what you liked, didn't like, blah, 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 so I can change it. Awesome. I'm totally. I'll bring snacks.
Although this is nice.
email.
When we did this, we did this one, we brought wine.